turnout after lunch. Well, I'm actually humbled and delighted to be sharing the podium with Andrew Rossetti. As you know, he's really done a lot for this meeting today. But alongside him, I want to take the opportunity to congratulate the program committee for having brought together so successfully so many national and international talent here in one room. I believe that the opportunities for advancing music therapy are phenomenal. So the way we organized it is I'm just going to spend about 10 minutes or so and then turn the podium over to Andrew. Okay, we have nothing to disclose. This represents both Andrew and my disclosure. This is just a summary of our learning objectives. So just looking at the 2013 statistics, there were over 230,000 women that were diagnosed with breast cancer in the United States and North America. And approximately 40,000 women died from the disease. When you look at the stage distribution, which is the table below here, you see that the majority of the deaths occur among women who present with advanced stages. We're fortunate that women are pursuing routine screening, and therefore 2/3 of the population is really diagnosed in the early stage disease, which has a very favorable outcome. And so as a result of this incidence and outcomes pattern, we find that there are significant populations of women that face a continuum spectrum of disease, from diagnoses to treatment, further along survivorship and life after breast cancer. Therefore, more important and more compelling than any other cancer, it is in breast cancer that I believe we need an organized, multidisciplinary approach where they're converging of disciplines to give the patients the best outcome. The focus today in this multidisciplinary talk is really integrative oncology. What are the interventions that we think about when we want to support a patient's quality of life, reduce stress, and promote well-being? I realize that in this audience we have a range of healthcare professionals, and I thought I would take a moment just to briefly review with you the discipline of radiation oncology. In this slide, I have there are two broad categories by which radiation therapy is administered. One is the external beam radiation therapy, and on your left here is very sophisticated mega voltage linear accelerator. These are very expensive units and are used to deliver most of the radiation therapy that we are treating our patients with. On the right is brachytherapy. That's another kind of radiotherapy where tiny pellets are left in proximity of the tumor. This is an example of a breast with pellets, and this is an example of a prostate gland with brachytherapy pellets. We have had significant advances in the field of radiation therapy. Today, every single patient gets three-dimensional radiation planning. In this case, you're seeing a CAT scan with where you can see the breast volume outlined, the lumpectomy cavity, as well as the relationship of the breast to the lung and the heart. And it is this 3D rendering that I take into account as we are defining the radiation targets and the radiation beams, so that we spare as much as reasonably achievable the normal structures while we are trying to target the tumor and get a cure. Lower down, we also have had significant technological advances in the treatment planning software and treatment delivery. I also want to take you through an experience of a patient that comes into a radiation oncology practice. The first thing is the patient is seen in consultation, at which time a decision is made whether or not radiation therapy is an appropriate intervention. Following the consultation, there is this simulation. You heard that yesterday and you're hearing that again. It's basically a fitting session for the actual radiation therapy. Immobilization that's appropriate to that anatomical site is created. The idea of the immobilization is that we can reproducibly and reliably position the patient day after day for the daily therapy. In this case, you see an example of a head and neck with a mask. Once the simulation mask immobilization is established, then you do a CAT scan, and the patient, of course, is then ready to go home. And we have what is called a virtual patient, and we work with this virtual patient to come up with an optimized radiation plan. In this case example, it's a head and neck case. All the anatomical structures that are relevant and important in this case have been outlined. And a final complex radiation plan with multiple beams, as you can see, has been generated. And there now the patient's simulation and treatment planning is ready, and the patient is now ready to come for their daily therapy. And it is this daily therapy session that you have been hearing about that is over and above the simulation session, another opportunity for us to support the patients as they are being taken through these daily visits. In addition to daily, weekly clinical medical evaluation, we also have the advantage of physical therapy, we have the advantage of integrative oncology services that are made available to the patients. Okay, so we have in the umbrella of integrative oncology 3 trials that were initiated at Beth Israel. All 3 are IRB approved trials. The first one is guided imagery relaxation. This study has been completed. The second is the randomized study on the role of acupuncture in the management of hot flashes in patients with breast cancer. This study is ongoing. And the third study is the randomized study evaluating the impact of music therapy on the patient's stress level at the time of simulation. And this study, the accrual has been completed and the analysis is still pending. And I will leave any further discussion on this for Andrew to give us during his session of the talk. Before I describe our studies, I just wanted to share with you this particular data. This slide is summarizing the levels of evidence that have been described in medicine that guide us to evaluate and judge the strength of a trial. And so if you have conducted a trial, which is a randomized controlled trial, then that is level 1 evidence. That is the strongest evidence that is there to perhaps justify a new treatment or justify a practice change. And as you go down, level 2 is also a strong trial, but it's non-randomized, but has controlled variables. It's controlled against, already known literature and so on and so forth. Whereas as you go down level 3, 4, and 5 is the weakest, which is an expert opinion without any clinical appraisal. And it's important for us to think about this, especially for all of us in this room, as we want to advance integrative oncology, music therapy, shoulder to shoulder alongside other co-disciplines. Well, if you have to do that, then you have to walk the walk and talk the talk. And I ran a literature review for music therapy, and there are 20 level 1 publications, meaning there were randomized trials that would fit the criteria level 1. However, of those, only 2 are in cancer. So it tells us that we have a lot of work to do. So I'm going to give you one quick example of a level 1 trial that was practice changing. This is early on in the 1980s, we had multiple randomized trials that compared mastectomy to breast conservation, meaning women did not have to lose the breast, only the cancer was removed and the remainder of the breast was treated with radiotherapy. So the 2 randomization arms was radical mastectomy and breast conserving therapy. This is a publication out of the New England Journal of Medicine, now giving us 20-year follow-up to that randomized trial, and you can see the survival curves totally superimposed. This is a powerful level 1 evidence that changes practice. And that is the evidence of that practice. So when you look In the 1980s is when this trial was initiated, and today as we are progressing worldwide, there is a change in practice, and we're increasingly doing breast conservation as opposed to mastectomy. So let's go back to the trials that we have embarked on here at Beth Israel. The first study is a study that evaluated the impact of guided imagery relaxation in patients that were coming for the daily therapy. So the treatment plans were complete, they were all committed to a course of radiation therapy, and that is when they were being enrolled in the trial. This was a prospective study. It was a single-arm study. The objectives were, we had to evaluate primarily the relaxation that the patients experience on guided imagery. For that, we wanted two kind of objectives. Subjective is when the patient says, aha, I feel wonderful. How do you measure that? Your aha is louder than her aha. Does that mean you did better than her? So therefore, in addition to subjective is very important because it matters to us what our patients think, but objective measures are also critical. So in this particular study, we took physiologic response as our objective measures. What that was skin temperature, thermal biofeedback. No aha will change that. It is what it is. Blood pressure it is what it is. Respiration rate. In addition to that, we also used subjective measures, which was the symptom distress thermometer. Now these are tools that are validated tools, that are, again, things to think about. If you want to do a study, use tools that are well respected and reliable. So the validated symptom distress thermometer was used as a subjective measure. And of course, the EQ5D you're all familiar with was completed before and after the course of radiation, and patient satisfaction was turned in at the end of radiation. The patient characteristics are in this table. There were 66 patients that we enrolled. The median age was 57 years. The majority of the patients that we enrolled were in the early stages, as you can see here. Some population of the patients also had received adjuvant chemotherapy. On an average, 4 median number of guided imagery sessions were attended to by in the presence of the integrative oncology nurse. So just tells you that the majority of the patients had a good exposure to this intervention. And these are the results. Now this is a summary of the objective results. As you can look down, respiration rate before and after. So this table here, the first one is pre-session. This is respiration, pulse, systolic, diastolic blood pressure, and temperature. And this is after a guided imagery session. And you can see the respiration rate lowers, the pulse lowers, the pressure comes down, and the temperature goes up, indicating vasodilatation, relaxation. And all these differences we observed were statistically significant. Looking at these subjective measures, which was the patient's aha, they were very satisfied. 85% of the patients said that they really appreciated this intervention, and 100% said they would recommend it to another patient. When you look at the EQ5D, you would see that the anxiety and depression, which is in red, came down consistently in the beginning and at the end. However, you saw the pain and discomfort went up. And that's very easily explained because patients, as they complete radiation therapy, are experiencing side effects of skin reaction and sensitivity. And so that is the explanation for why we saw breast pain and or discomfort reported more at the end of treatment than at the beginning of treatment. So all in all, a very positive study. The second study that we currently are doing, again thinking about the study design, a randomized placebo-controlled trial. What that means is half the patients are going to get acupuncture, other half are going to get sham acupuncture. The acupuncture arm is going to get acupuncture on the Chinese medicine diagnosis and pattern identification, whereas the placebo is going to be given using Streitberger needle device. So the patient doesn't know whether they're getting the real or the sham, but the randomization pattern will keep that record. The primary objective of this trial is to study whether acupuncture really affects hot flashes and night sweats. I mean, is it just a placebo effect because somebody came and did the pink, is there that psychosomatic effect, or is it real? And that is a very important study, because in breast cancer patients, a significant number of them suffer the symptom, and almost all of them are fatigued with taking medication. They do not want another pill or another medication with side effects to treat their hot flashes. So if you have a holistic approach, a non-toxic approach, it would be phenomenal. Our goal is to accrue 90 patients. We have to date accrued 20. We've screened many more. Randomized trials are always tougher to do. Accrual is always slower. The third trial, which I said I'm going to leave the thunder for Andrew Rossetti here to talk about, is a study that is meta-accrual. This was again a randomized trial. This was focused on the simulation procedure. Half the patients were going to get the intervention and the other half were not. And the outcomes here were going to be patient-reported outcomes. It is all about the patient experience. And so we'll find out what these results show. So as we deliver personalized care, which is the motto of today's provider, I mean, this is our goal, we have to focus on the diagnosis, the cell type, the biology of cancer, the stage of cancer, and taking all that information, we are looking at multidisciplinary coordination of care, arriving at a very thoughtful treatment plan for that particular situation, and then coordination of the medical care that follows, such that the treatment plan that we have outlined is carried out. Also making sure that we have medical resources and facilities, that the treatment, where the treatment is going to be given is safe for the patient and is being given by well-credentialed physicians. And of course, after the treatment is over, then you want to give the patient an individualized survivorship plan, which not only tells them, you've got to see the doctors, you've got to get blood work, but really also educate them on modifiable factors that promote healthy lifestyles. But in all of this continuum of care, we recognize that stress management is not being addressed. That is genuinely an unmet need, and one that is very important and ripe for research. When I think about that, and I think about music therapy, I think music therapy is like a glove when it comes to personalizing care. It fits like a glove. It's as individual gets. It's as personal can get. And it is non-invasive. It is non-pharmaceutical. It is not associated with toxicities. And so really what the onus for all of us is to continue to pursue trials so that we can find a defined role for music therapy in cancer care. With that, I'll pass on.